In the first two videos of this series on HRT, we spent a lot of time on what went wrong. We looked at the Women's Health Initiative, what it actually tested, who it actually studied, and why the interpretation of those results caused 20 plus years of unnecessary suffering for women who were refused hormone therapy based on a profound misreading of the data that came out of that study. Today we're going to pivot, because understanding what the WHI got wrong only matters if it points us toward what getting it right actually looks like. And it does. The same evidence base that reveals the WHI's flaws also points directly toward the hormones, the timing, and the monitoring approach that makes modern hormone optimization safe and genuinely transformative for most women in perimenopause and postmenopause. So today we're talking about three specific hormones: estradiol, micronized progesterone, and testosterone. We're going to talk about why each one is fundamentally different clinical choice from what the WHI tested. We're going to look at the evidence behind each one, and we're going to talk about how you take these hormones. The delivery method matters clinically almost as much as which ones you're actually taking. Hello again. I'm Dr. Greg Oliver. So let's get started. The estrogen used in the Women's Health Initiative was Premarin, horse estrogens, derived from the urine of pregnant mares. Premarin contains dozens of different estrogen compounds, some of which are biologically active in the human body in ways that 17-beta-estradiol, the estrogen your ovaries actually produce for most of life, simply is not. They weren't equivalent. 17-beta-estradiol, we call estradiol, is what's known as a bioidentical hormone. It's molecularly identical to the primary estrogen your body made before menopause. When we prescribe estradiol today in a patch, a gel, a cream, a pill, we're replacing as precisely as pharmaceutical science allows the hormone that your body was already used to having, used to making, and used to putting into its metabolic activity. These horse estrogens are not that. It's a mixture of compounds that included things like equine and equilenin, horse estrogens that have different half-lives, different receptor binding profiles, and different metabolic effects than human estradiol. They are not interchangeable. Now, does that mean Premarin is inherently dangerous? Not necessarily. As we covered in my first video, video 1, the estrogen alone arm of the WHI, which used Premarin in women without their uterus, actually showed a reduction in breast cancer over the 20-year follow-up period. So Premarin without synthetic progestin has its own story. But when we're asking whether we can do better, whether there's a form of estrogen replacement that more closely mimics what your own body naturally produced with a cleaner metabolic profile and mounting evidence for heart and cardiovascular benefit, the answer is estradiol. And that's why estradiol, not horse estrogen, is the foundation of a modern evidence-based hormone optimization protocol. Think of it this way. If your car runs on a specific grade of fuel that it was designed to use, you can probably run it on a fuel blend that contains some of that grade and some other grades, but it won't run as cleanly, and you can't assume the benefits will be identical. Estradiol is the grade of fuel your body was designed to run on for 30 or 40 years, and that matters. Now, we get to the hormone that is arguably the most important distinction between what the WHI tested and what modern hormone optimization looks like, and that hormone is progesterone. When a woman still has a uterus and takes estrogen, she also needs progesterone, or a progesterone-like compound, and that protects the uterine lining from being overstimulated by just the estrogen. Without it, unopposed estrogen raises the risk of endometrial cancer. That's well established, and there is no controversy to that statement. The question, however, is which progesterone? And that question turns out to have very consequential answers. The WHI study used medroxyprogesterone acetate, or Provera, which is a synthetic progestin. It binds progesterone receptors, which is why it protects the uterus, but it also interacts with androgen receptors, glucocorticoid receptors, and other hormonal pathways in ways that natural progesterone does not. And as we discussed in video 2 of this series, the breast cancer signal in the WHI was concentrated in the combination therapy arm, which was Premarin plus Provera, not in the Premarin or estrogen alone arm. Micronized progesterone is a very different compound. It is bioidentical, molecularly identical to the progesterone your body produced throughout your reproductive years. It is processed by micronization, which means they grind it into very small particles, which allows it to be absorbed effectively in its oral form, so it can be taken orally. Now, let's talk about the data. There was a very large French study which followed 80,000 women for more than 8 years and specifically compared the breast cancer risk associated with different types of progestogens. The results were striking. Women on estrogen combined with synthetic progestins like the Provera had a statistically significant increased risk of breast cancer compared to the ones that were not on that synthetic. But women with estrogen combined with natural micronized progesterone showed no statistically significant increased risk. They had no extra risk. An analysis that included that French study data confirmed breast cancer risk was approximately 33% lower in women using estrogen with bioidentical progesterone compared to those using estrogen with a synthetic progesterone like the Provera. This is clinically meaningful difference, and it's the reason that modern hormone optimization, like in my practice and in the practices of fellowship-trained hormone physicians across the country, micronized progesterone, not synthetic progestins like Provera, is the standard of care for women with a uterus. Big difference there. I want to be clear about one nuance here. Micronized progesterone, particularly at high doses, used continuously, can have some effects on endometrial cancer risk, so that requires some monitoring. This is one of the many reasons why a lot of supervised hormone optimization with proper follow-up isn't the same as getting a prescription mailed to you from a telehealth service. Monitoring of the patient matters, and we'll cover that fully in my next video, video 4. Here is the conversation that almost nobody was having or is having with menopausal women. Testosterone. Now, most people and most women think of testosterone as a male-only hormone. It is not. Women produce testosterone throughout their lives. They produce it in the ovaries and in the adrenal glands. And just like estrogen and progesterone, testosterone levels begin declining in the late 30s and early 40s, often well before other menopausal symptoms even become obvious. By the time a woman is postmenopausal, her testosterone levels may be only a fraction of what they were at their peak, and testosterone receptors are distributed throughout the entire female body. They're in the brain, the bone, the muscle, in sexual tissue, in the cardiovascular system. So when testosterone falls, the effects show up in ways that are often misattributed to things like depression, aging, or stress. So, what does low testosterone look like in a woman? Well, it can look like a loss of libido or sexual desire, not just reduced interest in sex, but complete disappearance of sexual drive that used to be normal. It can look like fatigue that doesn't respond to sleep. It can be difficulty building or maintaining muscle, even with exercise. Brain fog is common, mood flatness, not quite depression, but a dimming of that mental spark. Difficulty with motivation, joint pain, and a general sense that the energy and drive you had in your 30s has just quietly left the building. Does that sound familiar? For a lot of women it does, and for a lot of women, those symptoms are being treated with things like antidepressants or just accepted as part of aging. You're getting older, when the actual driver may be a hormone deficiency that's very, very treatable. The primary evidence-based indication for testosterone therapy in women is hypoactive sexual desire disorder or loss of libido, clinically low libido in the absence of other explanations. Multiple randomized controlled trials have confirmed that physiologic doses for women of testosterone significantly improve sexual desire, arousal, frequency of sexual activity, and satisfaction in postmenopausal women. But the evidence and clinical experience increasingly point to additional benefits of testosterone: bone protection, muscle preservation, cognitive support, cardiovascular effects. The larger long-term randomized trial data in women is still catching up to what the observation and clinical experience has been showing for decades to doctors like myself. What we can say with confidence is that testosterone has been used safely in women for over 80 years, and the growing evidence base supports its careful clinical use well beyond just sexual function. There's one more thing worth noting. There is emerging data suggesting that physiologic testosterone may actually have a protective effect on breast tissue, the opposite of what many women fear. 2 large peer-reviewed studies have reported a significant reduction in the incidence of invasive breast cancer in women who are on testosterone therapy. This is an active area of research and not yet part of mainstream guidelines, but it is a meaningful signal that deserves continued attention, and studies are ongoing. So even when you have the right hormone, the way you take it matters. This is not a minor detail. It has real clinical implications, particularly for things like cardiovascular issues and clotting risk. So let's focus on estradiol, because this is where the route of administration data is the most clear of all the hormones. Oral estradiol, a pill, goes through the digestive system when you take it by mouth and is processed by the liver before entering the bloodstream. This first pass liver metabolism affects how the body handles it, including effects on clotting factors and blood pressure regulation. Multiple studies and current guidelines indicate that oral estrogen carries a measurably higher risk of blood clots and stroke compared to transdermal or through the skin delivery. Transdermal estradiol, which is delivered through a patch, a gel, or a cream applied to the skin, bypasses the liver entirely when it passes in the body. It enters the bloodstream directly and maintains more stable blood levels throughout the day without the spikes and troughs that are associated with oral dosing. And the data is consistent. Transdermal estradiol does not appear to carry the elevated clot and stroke risk associated with oral estrogen when it's used at standard doses. Now, for women with a higher baseline risk for blood clots or stroke, those who are overweight, have a history of high blood pressure, or other cardiovascular risk factors, transdermal delivery is particularly important. New guidelines specifically recommend transdermal therapy for women at elevated clotting risk. Similarly, for progesterone, oral micronized progesterone has one well-documented side effect. It can cause a little bit of drowsiness in some women when taken at bedtime. The reason is because progesterone will be metabolized into a compound with mild sedating properties. Now, for most women, this is either a neutral side effect or actually helpful for sleep, which is often a significant menopausal complaint. We give it at bedtime, but it's something to know going in, and dosing and timing can be adjusted accordingly. So let's look at testosterone. For testosterone women, transdermal delivery, cream, or gel is generally the preferred approach at physiologic doses. It allows careful titration of dose and avoids the liver metabolism issues that come with oral androgens or testosterone. Pellet therapy, which is subcutaneous insertion of testosterone pellets, is another option that offers sustained levels without daily application and has published peer-reviewed safety data spanning several years in large patient groups. The bottom line on delivery of these hormones, the right hormone in the wrong form at the wrong dose delivered the wrong way, can look very different clinically than the same hormone done correctly. This is one of the many reasons that hormone optimization is not a prescription by mail service. Route, dose, timing, and formulation are clinical decisions that require individual assessment and ongoing monitoring. I've been practicing medicine and supervising hormone optimization for a long time. I went through an 18-month fellowship specifically because I was watching women in my practice age more quickly than they should have been after menopause. And they were suffering from a lot of those effects, unnecessarily from symptoms they'd been told were just part of getting older. No doctor should be just saying that. We should dig into it. When hormone optimization is done properly with the right hormones, delivered correctly, dosed individually, and monitored appropriately over time, the changes I see in patients are not subtle. They are dramatic. Women who spent years barely sleeping because of night sweats start sleeping through the night. Women who watched their weight creep up despite eating reasonably and exercising regularly find their body composition begins to respond once again because hormones govern metabolism at a fundamental level. Women who'd quietly accepted that the woman they used to be was just gone find that she's come back. Brain fog lifts, joint pain often improves, mood stabilizes, energy returns, and libido for many women, something they'd written off entirely, becomes part of their life once again. So, beyond the quality of life benefits, properly managed hormone optimization has documented effects on long-term health outcomes. Improved bone density and bone preservation, reducing the fracture risk that becomes a leading cause of disability and death in older women. Cardiovascular and heart protection when initiated in the timing window we discussed in video 2. And a growing body of evidence on cognitive protection and dementia risk reduction. These are not minor quality of life perks. These are meaningful contributors to how well you age physically, cognitively, and metabolically. And for most healthy women under 60 or within 10 years of menopause onset with no specific contraindication, the evidence now strongly supports that the benefits of properly managed hormone optimization outweigh the risks of using these hormones. 20 years of unnecessary suffering because a study was misread. That's the reality, and it doesn't have to continue. In video 4, the final video of this HRT series, we're going to walk through exactly what proper hormone optimization evaluation and monitoring looks like in my practice, what labs we run, what we're looking for, how we individualize dosing, what the screening process looks like, and how ongoing supervision and monitoring makes the difference between safe, effective hormone therapy and guesswork. Now, if you've made it through all 3 of these videos, you now understand more about the real science of female hormone optimization than most physicians were ever taught in medical school. And you're ready for the practical conversation as to whether hormones and you will work together. If this series has been valuable, please share it. There are women in your life who've been told that there's nothing that can be done as they've been aging, women who are sleeping badly, gaining weight, losing themselves to brain fog and fatigue, and a libido that's gone silent. Share this with them. Give them the information that they deserve. I'm Dr. Greg Oliver, and I'll see you in video 4. Until then, so long.